So common mistakes, I've got about 25 common mistakes. I won't be covering them all because I just covered some of them in the dementia lecture. All right, but number one, my doctor told me it was because I was old. A lot of doctors get fired for saying this too often. I say it anyway, but when I say it, I try to make sure people know I'm joking. Because it's not true for most conditions, except for, you know, gray hair and wrinkles and that sort of thing. And ultimately, it conveys a message that the patient's no longer important enough to bother with. So, it's not therapeutic, because after all, if you've got back pain and you're 85 years old, and your doctor tells you, what do you expect? You're 85 years old. Come on, you're going to expect a little back pain. What does that tell them for when they're 90, if they're unlucky enough to live to be 90? That it's going to be excruciating? It's probably not a good idea, and viable therapeutic options go overlooked. Number two is talking to the daughter and ignoring the patient. This is my most common mistake. And the more pressured we are for time, the more likely we are to do this, especially when our patient is either visually impaired, hearing impaired, or cognitively impaired. So it's sometimes difficult to avoid, but the best way to avoid this, I think, is to just be aware of it and try to set up your exam room or your office room in such a way that you can talk to that daughter, because technically if somebody has dementia or can't hear you, you need to talk to that daughter, but have them situated right across or right alongside of the patient. So you can talk to both of them at the same time and it's not so obvious. So you're doing this, back to there, back to there. Number three is seeing nursing home patients in the office. How many of you guys do this? Don't you find it difficult to get information? You know, typical nursing home patients, very history impaired. I think to see them in the office, it takes longer. You have less information about them because you don't have a nurse's aide or a nurse that may know what's going on with them on a day-to-day basis, and they occupy more of your office staff. So I'd recommend doing it in the nursing facility. So you have an artificial environment of the office. You have no collateral source of information. I think it's more time efficient in the nursing facility. I probably shouldn't be on tape saying this. I can't do a office-based visit in less than 10 minutes on a nursing home patient. But I can often do a visit at a nursing home under 10 minutes. So I think it's more time efficient and more cost effective to do it in the nursing home. Number four is seeing nursing home patients without a nurse, closely related to number three. Because I think nursing home input or nursing input is critically important. The typical nursing home chart weighs about 5 pounds. In that 5-pound chart, there's maybe 1/10 of an ounce of useful information to you in terms of making a clinical decision. So the nursing staff can help you find the important information or provide you the important information, which may not be in the chart at all. And by rounding with a nurse or communicating with a nurse, it cuts down on phone calls, it improves your coordination of your care plan, it allows an opportunity to teach the nurse, and sometimes teaching is so effortless, all you gotta do is be thinking out loud as you're writing, and you can get your point across. And you know, it allows the nurse to know why you did what you did, so she can explain to the daughter why you did what you did, so that the daughter doesn't call the office later wanting to know what you did. All that doesn't happen as readily without rounding with a nurse. Number 5 is making nursing home rounds on your day off. Not a good idea. And this actually happens. I've talked to many rural docs, and I ask them what their practice is like, and they'll say something along the lines of, well, I have every 4th weekend, I'm on call, but I have every Thursday off. So what do you do on Thursdays? And I get up and I go over to the office and get caught up on paperwork, and then I go over to the hospital and get caught up on dictations, and then I have lunch at the hospital, and then I go out to the Shady Rest nursing home and do nursing home rounds. That's not a day off. And it really relegates your nursing home patients to second-class citizenship, if you ask me. And I mean, I certainly would resent it. So the reimbursement nowadays for nursing home visits is such that you don't lose money doing it, especially if you can do several during your session. When I started in geriatrics, and I know you'll be amazed because I look so young, but when I started in geriatrics, the Medicare paid $19 for a nursing home visit, and 80%, you know, they only paid actually 80% of the $19, which is $16. Okay, and you could only do one visit per month, and then this Nursing Home Reform Act that was part of OBRA in 1987 came out, and things got a lot better. So now you can basically charge similar rates to what you would if you saw people in the office, and you can see people as often as is medically necessary. Number 6 is the delayed diagnosis of dementia. We don't need to talk much about that because we just did, and it's Saturday. Number 7 is failure to treat dementia. I think it's a mistake not to treat dementia. Okay, and the way I would treat dementia is if you have mild dementia, I would treat people with a cholinesterase inhibitor plus or minus memantine. Cholinesterase inhibitor first, though. With moderate dementia, I would definitely use both. And with severe dementia, I would use memantine plus or minus a cholinesterase inhibitor. But usually you should be on 2 meds. Number 8. First-line treatment of agitation with benzodiazepines. We talked about that too, and how it used to be that if you were a state surveyor, you could look at a person's a facility's prescribing of benzodiazepines and know right away whether or not you got behavior problems or a problem with behavior management in the facilities. Excessive use of benzos is a red flag that you're not doing good behavior management. And of course, most behavior management is accomplished by non-pharmacologic means that I didn't even mention. Good nursing facilities know how to do this better than poor nursing facilities who just rely on the drug all the time. PRN analgesics for dementia patients is in general a bad idea. Because very few people with dementia can say that it's been 4 hours since my last Vicodin, can I have another, because my back is really hurting. They're more likely to get agitated and you end up playing catch up. So I would routinely schedule your analgesics, even the opioids. So something like oxycodone, 5 milligrams, TID while awake, something like that. Yes?
Have you run into, I try and do that at one of my nursing homes, or at least I like to do that, but I've run into difficulty where they're frequently asking to make them PRN because they have difficulty with patients declining the medication.
That surprises me because I usually have the other request. That is, since we're given this TID PRN, can we just make it routine? And I think if they make it routine, they don't have to do a certain amount of charting. So a PRN pain medicine requires charting that they do to address the efficacy of the PRN measure that you just took. Whereas if it's scheduled, you just give it and not have to worry about it. And the supplies are more routinized too. So I'm just surprised to hear you say that. Yes?
I've also run into problems where nursing homes have reported that auditors give them trouble on PRN medicines, that it's easier to have a routine medicine.
Yeah, the comment was about it being easier to have a routine medicine. Another thing is, by the auditors, you mean the surveyors?
State auditors.
Yeah, state surveyors, right. If a state surveyor sees that you're using PRN pain medication on a daily basis, that is a red flag to them that your pain control program is inadequate. You shouldn't have to use a PRN every day. You're not getting enough regularly scheduled medicine. So good point also. I think we got to err on the side of scheduled. Number 10 is sensory deprivation masquerading as dementia.